Hello. Hello.
Hello, madam.
Yeah. So shall we start? Sorry for the delay.
Okay, madam.
Okay. So shall we start?
Can you hear me?
Yeah, I can hear you. So I just want to talk to you for a few words regarding, this is, can you see me?
Yes, madam.
Right. I'm Dr. Malkanthi Galhena, the president of the Sri Lanka College of Specialist Family Physicians. So, regarding so our duty is to provide first contact care, mainly curative, but opportunistic health promotion we are supposed to do. So that's what we got our training. So where we are there to strengthen the primary care system in the country, because except the all other units, that the wards and other the clinics are being are being work the facilitated their work by the presence of consultants, but in the outpatient department of the state sector hospitals of Sri Lanka, yet have not been provided the supervised care. But the Ministry of Health in 2023 taken the decision according to the health policy, new health policy, under the strengthening of the primary care system in Sri Lanka. They have placed us to the Apex Hospital to look after the surrounding population, as well as to they provide guidance to provide the care for the cluster systems which they have the identified divisional hospitals, as well as the smaller hospitals where they need to function, but they don't have the specialist cadre. So that is our duty. For the registrars in family medicine, we train them having that objective to fulfill the country's requirement to provide the first contact care under the best supervision, according to the provision of the best evidence-based care for our patients, in order to provide the safe patient, the safety of patients, as well as to reduce the morbidity and the mortality of the country, which is beyond our control at the moment. So because of that, I hope that we are there to provide. That is our utmost, the duty to do for all primary care providers, the doctors especially, to provide the best evidence-based care when you are getting patients at first contact care, whether to treat and whether to follow up, or whether to hand over these patients to the other specialties. So that is our prime duty. So because of that, our registrars are being trained with that knowledge, in order to provide the maximum patient protection, patient safety, as well as the centered care in this country. So I will hand over this presentation to Dr. Achini, our registrar in family medicine, to provide that knowledge, based on the evidence based on the case scenario, which we have managed at the base hospital Panadura. As the president of this college, and as well as I'm the consultant family physician to that unit, I have been guided these my trainees to provide the evidence-based care. It's over to you, Achini. Now you can start.
Thank you, madam. Can you see my screen?
Yeah, can.
Good evening, everybody. I am Dr. Achini Bogahakumbura, registrar in family medicine. Today, I am going to discuss a clinical scenario of a 62-year-old male patient who presents with acute shortness of breath, and discuss the management of chronic obstructive pulmonary disease according to the GOLD guideline. To update your knowledge about the latest guidelines on COPD. This is my clinical scenario. My patient was a 62-year-old male who was a Mason, known patient with COPD for 10 years, and he was a heavy smoker and stopped smoking 3 months back. He presented with acute shortness of breath with productive cough for 1 week with white sputum, and he had dyspnea on slight physical activity. He had functional impairment of daily activities due to shortness of breath. He had no diurnal variation of symptoms, no chest pain, orthopnea, or paroxysmal nocturnal dyspnea, no fever, no hemoptysis, no loss of weight or loss of appetite, no problems with sleep or appetite. He has had 2 hospital admissions in this year and 1 admission last year due to acute exacerbations of COPD. His past medical history: he is a non-COPD patient for 10 years, diabetes mellitus for 5 years, and he has no history of lung malignancy or tuberculosis, no bronchial asthma, no hypertension, no ischemic heart disease. Past surgical history is not significant. His drug history: he was on metered dose inhaler salbutamol 400 micrograms BD, metered dose inhaler salmeterol and fluticasone 250 micrograms BD, and for diabetes, he was on metformin, glycoside, and sitagliptin, and he was on atorvastatin. He had no known allergies, and family history was not significant. No lung malignancies, no COPD, no bronchial asthma. Social history: he has smoked more than 10 cigarettes per day for 30 years, and he has stopped 3 months back due to medical advice. He is exposed to cement dust at his working place as he is a mason, and no allergens or irritants at home environment. His wife is a housewife. He has 2 children who are occupied. He has some worrying thoughts about the disease affecting day-to-day life and his job. On examination, general examination, the patient is averagely built, not wasted, mildly dyspneic and plethoric. He is not cyanosed, no lymphadenopathy. Hydration was good. He had acanthosis nigricans. No nicotine stains of nails, no clubbing, no ankle or sacral edema. On examination of the respiratory system, his chest is hyperinflated. Respiratory rate was 24 breaths per minute, and he was using accessory muscles of respiration, and chest expansion was reduced. Trachea and apex beat were not shifted. Percussion note was resonant. Vocal fremitus normal. He had bilateral rhonchi and coarse crepitations. His saturation of oxygen was 96%. Examination of the cardiovascular system. His jugular venous pressure was not elevated. Pulse rate was 96 beats per minute. Blood pressure was 125 by 80 millimeter mercury. Heart sounds were normal. No basal crepitations. Abdominal examination was normal. These are the investigations we did. We did a full blood count. Hemoglobin was 13.2. WBC count was 9. Eosinophil count was 2.2%. That the absolute count was 198 per microliter. And his C-reactive protein was 2.5. Chest X-ray was hyperinflated lung fields were there, no other abnormalities. ECG, there were no abnormalities, no features of copulmonale. Fasting blood sugar was 115. This is the pharmacological management we did. We gave metered dose inhaler salbutamol 400 mics BD, which he was previously on, and we added metered dose inhaler ipratropium 500 micrograms BD and metered dose inhaler salmeterol and fluticasone 250 micrograms BD. We started the short course of prednisolone in a tailing off regime for 15 days. And we gave azithromycin 500 milligram daily, and we continued usual drugs for diabetes and statins. And this is the non-pharmacological management we did. We reassured the patient about the illness, counseled about the disease in a clear language, physiotherapy and breathing techniques, check the inhaler technique, advised and checked on drug compliance, advised on avoidance of allergens and the importance of smoking cessation, and we gave advice on influenza and pneumococcal vaccination. And we sent him for spirometry, and we continued other medication for diabetes. We advised on strict glycemic control and with home blood sugar monitoring with fasting blood sugar and postprandial blood sugar charts, and strict follow-up and plan to review in 2 weeks. We advised on nutrition and balanced diet. Then I'll go to the discussion of management of COPD. COPD is a long-term and progressive illness. And now,
Can I stop for a little while?
okay, ma'am.
Since this patient is non-patient of COPD, so you have to, it's a must for you all to do the best evidence-based, the management, even though we think we are correct. So because of that, the provision of knowledge to you all at this juncture, right? After giving the patient case scenario, it's very important. So because of that, you listen to the gold guidelines, which, the clearly, the mention how to, the manage our patients of COPD, not, the thinking about yourself, but thinking about the guideline management to give them the better life. So that's what we are going to provide this knowledge hereafter. So listen to them, listen to Achini carefully, and she will explain that. Okay. So over to you, Achini.
Thank you, madam. COPD is a long-term and progressive illness. An outcome would be better if we diagnose the condition and intervene as soon as possible. So, as family physicians in first contact care, we should practice according to the best evidence. Therefore, competence in guideline management is very essential. Prevalence of COPD. At a global level, COPD prevalence in 2020 across both males and females was estimated to be 10.6%. COPD prevalence in South Asia is 6.3% with a prevalence in Sri Lanka of 10.5%. It demonstrates that COPD is a significant burden to both patients and healthcare services. So, definition of COPD. COPD is a heterogeneous lung condition characterized by chronic respiratory symptoms like dyspnea, cough, sputum production, with or without exacerbations due to abnormalities of the airways, that is bronchitis, bronchiolitis, and or alveoli, that is emphysema, that cause persistent, often progressive airflow obstruction. Risk factors of COPD are genetic factors like alpha-1 antitrypsin deficiency and environmental exposures like tobacco smoking and inhalation of toxic particles and gases from household and outdoor air pollution. Clinical presentation of COPD can vary. Patients can present with chronic dyspnea, chronic cough, sputum production, wheeze, chest tightness, fatigue. Additional clinical features in severe disease like ankle swelling in cor pulmonale and symptoms of depression or anxiety. We have to exclude other causes of chronic cough like intrathoracic causes like asthma, lung cancer, tuberculosis, bronchiectasis, left heart failure, interstitial lung disease, cystic fibrosis, idiopathic cough, and extrathoracic causes like chronic allergic rhinitis, postnasal drip syndrome, upper airway cough syndrome, gastroesophageal reflux, and medications like ACE inhibitors. Diagnostic criteria of COPD. A diagnosis of COPD should be considered in any patient who has dyspnea, chronic cough, or sputum production with or without a history of exposure to risk factors for the disease, but post spirometry that demonstrates the presence of a post bronchodilate FEV1 to FVC ratio of less than 0.7 is mandatory to establish the diagnosis of COPD. These are the differential diagnoses of COPD. They are bronchial asthma, congestive heart failure, bronchiectasis, tuberculosis, obliterative bronchiolitis, and diffuse panbronchiolitis. In the initial assessment, once the diagnosis of COPD has been confirmed by spirometry, in order to guide therapy, COPD assessment must focus on determining the following four fundamental aspects. Those are severity of airflow limitation, nature and magnitude of current symptoms, previous history of moderate and severe exacerbations, and presence and type of other diseases, multimorbidity. Goal grades and severity airflow obstruction in COPD based on post-bronchodilator FEV1. In COPD patients, that is FEV1 into FVC ratio less than 0.7. Goal grade 1 is mild COPD. It is FEV1 more than 80% of predicted. Goal grade 2 is moderate COPD. In that, FEV1 is 50 to 80% of predicted. Goal grade 3, that is severe COPD, FEV1 is 30 to 50% of predicted. And in goal grade 4, that is very severe COPD, FEV1 is less than 30% of predicted. This is the Modified Medical Research Council score or MRC scale. There are 5 grades, 0 to 5, 0 to 4, divided according to the severity of breathlessness. In MMRC grade 0, patient only get breathless when with strenuous exercise. MMRC grade 1, patient get short of breath when hurrying on the level or walking up a slight hill. In MMRC grade 2, patient walk slower than people of the same age on the level because of breathlessness or have to stop for breath when walking on my own pace on the level. MMRC grade 3, patient stops to breathe after walking about 100 meters or after a few minutes on the level. MMRC grade 4, patient is too breathless to leave the house or is breathless when dressing or undressing. In my patient, he was short of breath after walking about 100 meters or after a few minutes on the level. So he falls into MMRC grade 3. This is the COPD assessment tool or CAT assessment. In this, we analyze 8 symptoms and give a score of 0 to 5 for each symptoms. The symptoms are cough, sputum production, chest tightness, breathlessness on climbing stairs, limitation of activities, confidence of leaving home despite the lung condition, sleep, and energy. And there is a total score. We can calculate the total score. In my patient, his total score was 26 out of 40. Then I'll discuss on the GOLD ABE assessment tool. When spirometrically confirmed diagnosis of COPD, post-bronchodilator FEV1 to FVC ratio less than 0.7, then assessment of airflow obstruction should be done using goal grades, and assessment of symptoms or risk of exacerbations should be analyzed. So it is goal grade A is MMRC of 0 to 1 and CAT score of less than 10 and 0 or 1 moderate exacerbations not leading to hospitalization. Grade B is MMRC 2 or more, CAT score 10 or more, 0 or 1 moderate exacerbations not leading to hospitalization. Gold E criteria is 2 or more moderate exacerbations or 1 or more leading to hospitalization. MMRC or CAT score anything, we have to take my patient into category E, because he has had 2 hospital admissions this year. This is the initial pharmacological treatment according to the ABE assessment. In group A patients, a bronchodilator should be given. In group B, LABA and LAMA combination should be given. In group E patients, LABA and LAMA plus inhaled corticosteroid should be given if blood eosinophil count is more than 300. Then prevention and maintenance therapy. Smoking cessation is the main key to reduce the mortality in COPD. Then educating patient and caregivers, assessment of inhaler technique, pharmacological therapy, psychological support, nutritional support, pulmonary rehabilitation, and influenza and pneumococcal vaccinations. And in advanced disease, long-term oxygen therapy should be considered. Then long-term non-invasive ventilation, surgical or bronchoscopic interventional therapy, and in severe patients, palliative care. So management cycle is review, assess and adjust, and again review, assess. Then I'll discuss on the commonly used medications in COPD. Beta agonists. Short-acting beta agonists like salbutamol improves FEV1 and symptoms. Long-acting beta agonists like formoterol and salmeterol significantly improves FEV1 and lung volumes, dyspnea, health status, exacerbation rate, and number of hospitalizations, but no effect on mortality. Side effects like sinus tachycardia, potential for cardiac arrhythmias in susceptible patients, tremors, hypokalemia, tachyphylaxis can occur. Combination bronchodilator therapy. Combination of SABA and SAMA are superior compared to either medication alone in improving FEV1 and symptoms. Treatment with formoterol and tiotropium in separate inhalers has a bigger impact on FEV1 than either component alone. LAMAs have a greater effect on exacerbation reduction compared with LABAs and decreased hospitalization. Combination treatment with the LABA plus LAMA reduces exacerbations compared to monotherapy. Single inhaler therapy is more convenient and effective than multiple inhalers. Anti-inflammatory therapy in stable COPD are inhaled corticosteroids, oral glucocorticoids, phosphodiesterase 4 inhibitors, antibiotics, mucoregulators and antioxidant agents, and leukotriene modifiers. These are the factors to consider when initiating inhaled corticosteroid treatment. Factors against use are repeated pneumonia events, blood eosinophil count less than 100, history of mycobacterial infection. Factors favors use are one moderate exacerbation of COPD per year, blood eosinophil count between 100 and 300, and factors strongly favors use are history of hospitalizations for exacerbation of COPD, 2 or more moderate exacerbations of COPD per year, blood eosinophil count more than 300, and history of or concomitant asthma. Then I'll discuss about the triple therapy. Triple therapy is LABA plus LAMA plus inhaled corticosteroids. Triple therapy improves lung function when compared to LAMA alone, LAMA-LABA combination, or LABA-ICS combination. Then long-term oxygen therapy. Partial pressure of oxygen at or below 55 millimeter mercury or oxygen saturation at or below 88% with or without hypercapnia confirmed twice over a 3-week period, or partial pressure of oxygen between 55 and 60 or saturation of oxygen of 88% if there is evidence of pulmonary hypertension, peripheral edema suggesting congestive cardiac failure, or polycythemia, that is hematocrit more than 55%. Once a patient is placed on long-term oxygen therapy, the patient should be re-evaluated after 60 to 90 days with repeat arterial blood gases or oxygen saturation measurements while inspiring room air and the level of oxygen flow that had been prescribed to determine if oxygen is still indicated and if so, therapeutic. Then I'll go into acute exacerbation of COPD. The definition of acute exacerbation of COPD is an event of dyspnea with or without cough and sputum that worsen over less than 14 days. Differential diagnosis of acute exacerbation is pneumonia, congestive cardiac failure, pulmonary embolism. Treatment of acute exacerbation is short-acting beta agonist with or without short-acting anticholinergics. Maintenance therapy with long-acting bronchodilator therapy should be started. Systemic corticosteroids, antibiotics, and non-invasive ventilation if needed. These are the potential indications for hospitalization assessment. Those are severe symptoms such as sudden worsening of resting dyspnea, high respiratory rate, decreased saturation, confusion, drowsiness, acute respiratory failure, onset of new physical signs like cyanosis, peripheral edema, failure of an exacerbation to respond to initial medical management, presence of serious comorbidities like heart failure, newly occurring arrhythmias, and insufficient home support. These are the take-home messages. COPD is a progressive and long-term illness. So outcome would be better if the condition is diagnosed early and intervene as early as possible. As family physicians, it's important to update on the current guidelines as the first contact care. In conclusion, tackling COPD requires a multifaceted strategy that spans early detection, lifestyle modifications, individualized treatment, patient education, interdisciplinary collaboration, and a focus on proper nutrition and mental health. These are my references, and thank you. Special thanks to my consultant, Madam Malkanthi Galhena, for the enormous guidance and support provided. Thank you, Madam, and thank you, everybody.
Thank you, Achini. It's a wonderful, the presentation that you have done to provide the best evidence-based care to all who are practicing GPs as well as the trainees in order to go ahead with the current, the updates of management of the COPD. So it's a real wonderful, excellent, the presentation that you have done. So I must thank you being the registrar and family physician and the young bud that you are going to take the responsibilities of managing your patients in future. Even though I have given you the guidance, you have you have taken it correctly to provide the best the evidence-based care for our patients. That is being the family physician, even though we have not get this much of training, right? So you all who have joined today to this meeting, I'm going to give you the take home message, right? There are so much of the evidence based the practice and the resources available for you to go through. So Sri Lanka College of Specialist Family Physicians always they provide you for the best the evidence based care in general practice. As the specialist family physicians, we are so much responsible for the first contact curative care in our Sri Lankan patients. They can come to us, the places where we are working, Panadura, the Pliandala, Homangama, Gampaha, Watupitivala, Dambadeniya, Kiribathgoda, and there are so many places, Varakapula, so many places where the specialist family physicians are working. So not like the other consultants, you just can come to us without waiting, straight away with your patient findings and with the patients. So we are there to support you for that. And being registrars, we are going to train them to take the responsibilities of providing the best contact care for first contact care patients without any age, the discrimination and the gender. And irrespective of the symptoms, we are being trained to provide that in-depth, the knowledge to our trainees to give them the better first contact care. So, as a primary care physicians, to add one of few the important points for your management of COPD patients. First of all, you have to assess. First of all, you have to confirm them that they are COPD patients by taking history and as well as the examination techniques. Correct techniques matters more for you to go to confirm the diagnosis. Once you establish the diagnosis as COPD, then you have to go for them to give the best management option, because the lung tissue has already been damaged irreversibly, where you can reverse those lung tissues to back to normal. That is the physiology and pathology you must think about whenever you are meeting patient with COPD after the diagnosis by taking history and examination properly. So for that, you have to know the correct, the way to find out the information, that is the history, and to proper examination technique for you to confirm the diagnosis as COPD. So once your diagnosis is made, so that is your prime importance to provide the best evidence-based management to safeguard their lives as well as to ease the health burden to the country. So, being primary care physicians, whether you have trained or not, I'm delighted to provide this, the take-home message. Once you get the patient, once you come to the correct diagnosis with bilateral CO, the coarse crepitations with limited, the movements due to airflow, the limitation. So you confirm your diagnosis as COPD, then confirm whenever possible whether, by doing, definitely it's a must for you all to do the spirometry. So whenever it's not available at your practice, maybe you are working in the remote area in the hospital, but so try to send them to assess this, the spirometry assessment, because FEV1 ratio, FEV1 is very important. Forced expiratory volume in 1 second, it's very important for you all to manage the patient in future. So because of that, you being the primary care clinician, right, with or without training, you have to know where the spirometry, the assessment is available at the state sector or the private sector. So please, please, please be mindful to send them to, identify the stage of their illness of COPD by doing FEV1 ratio, FEV1 volume, the parameter. That's very, very important for the management of patients. If we think that it's more than, the 50 to 40, 50, it's less than 50 and less than 30. So we need to, assess them with very, very, the crucial attention. So because of that, sometimes we may have to transfer them, hand over them for the secondary and tertiary care. So that is the important thing. Whenever you want to hand over the patient, you need to. So we are not going to handle the patient taking the risk of the life of the patient. So that is very important. At the correct point of referral, we are ready to refer the patient for the secondary and tertiary care. So because of that, whenever you think that if you are getting a patient with the query COPD, send them for, the assessment of FEV1, that is the first, second, that the forced expiratory volume by assessing spirometry. So spirometry is compulsory. But although it's not available as the other countries in the hospital setup, there are places that it can be done for the reasonable amount. So which being I'm working at the Homagama based hospital, I know that the very good place that they are doing with the correct, the assessment is the medical faculty, University of Colombo, respiratory department. So I used to send them for the Dr. Lakmali. So once I send them, she will do the best option. The way that I'm sending for my patient for the nerve conduction test at Jayawardhanapura Physiology Department, they will do the best. Like that, you have to be aware where this can be done, even for the peripheries on Kurudangala. So you have to know where the place available for spirometry to do. That is COPD assessment. It's very, very, very compulsory. So after, the getting the assessment, you decide which grade of this patient is. It should be more than 50%, then less than 50% of expiratory volume in 1 second, or then less than 30. Like that, you can grade the severity of it. And after that, so as Dr. Achini correctly mentioned, the gold guideline mentioned that, you have to go for the MRC grade assessment. So you have to be very much, thorough with that. It's very simple. Even though it says that's the big thing, once you start putting to the practice, it will become just as natural and as convenient for your management for the patient safety. So in such a case, so you have to know, right, MRC, the guidelines, the management scales, as well as, the CAT, the assessment. After that only we are going to manage according to the best evidence-based management, which will par with international standards of management of COPD. So because of that, you should not be reluctant to, go through that, this goal guidelines management, and then treat your patients with COPD for them to have a better life. So there are the prophylactic antibiotics is compulsory for some patients according to the guideline. And long-term oxygen, which is not available in Sri Lanka, right? But some patients can afford. And as well as, the combined, even though we don't have the separate, the LABA and LAMA, we have combined, the LABA as well as the corticosteroids, which is a real benefit for our patients at the very early stages, according to the spirometry. So we can use nicely those combination therapy with, there are different, the types of combination therapies. They come as Seroflow, they come as Foracort, like that, the different, the budesonide, like that we can get. So the combination of salmeterol and the long-term LABA as well as the combination steroids. So which is very commonly available in our country, even though they say, so better go for the LABA and LAMA combination, which we don't have. But we have combination of LABA as well as the, the CM, corticosteroids, which will give the benefits the best for our patients. So we, without thinking, we should start, for such patients, LABA as well as the corticosteroid combination. Those are concise for a court, as well as the Serotide and Seroflow. There are so many combinations which we can use for our patients. the patients of this case scenario had frequent hospitalization, right? Since we have not sent for the patient for the spirometry assessment, but clinical scenario suggests, I told them to send the patient for the spirometry assessment. And after that, once we get that, it's in the hope of, the providing them the better assistant care to provide best the recovery. Once you get the COPD patient, please do the full blood count, because eosinophil count is more than 300 shows that you the clear in the inflammation it's going on, where you need to the optimize if the patient is on long-term the combination therapy, LABA and the CIS. Such a case, you have to optimize the therapy or to change to the long-term, the LABA and the CSI, like for a quad, if the patient was on Seraplo. So, and first of all, check the inhaler technique by your trainers and then confirm that the technique is okay. Then you have to think about, the optimization of the therapy. First therapy is the optimization of the LABA and the ICS therapy. To go for the 125 if the patient was on, then go for the 250 twice daily. But not only that, the ipratropium, it will give you the very good, the antimuscarinic effect. The LABA and the antimuscarinic effect will give the better relief. So please add the antimuscarinics like the ipratropium or tiotropium, which is long acting for patients benefit in a patient like this case scenario. I would like to add the tiotropium. The 9 milligram comes as the micrograms in inhalers. We can give them 18 milligrams in the double dose twice daily. So once a day first, right? Go for once a day. So which I have advised my registrar to go for that. So I think the patient may be benefited, and in 2 weeks time we are going to assess the patient again. So this is the take home message. First of all, whenever the patient comes with shortness of breath and the long term, the basis of shortness of breath and some cough and all. So irreversibility. Confirm the diagnosis of COPD. Then, after confirmation, send the patient for the spirometry is very essential, very important. And look for the full blood count. You assess your eosinophil count. It should be more than 300. In case you need to give them, that is the inflammation, ongoing inflammation. So which need to suppress by optimizing your inhalers. In case that combination therapy for 125 twice daily 2 puffs, then go for the maximum, and add on therapy by the ipratropium or tiotropium. And then not only that, because of the damaged epithelium of the respiratory system, they may need long-term antibiotic therapy, and always give them the support with to fight with the possibility of getting infections, frequent exacerbation, by adding them for prophylactic antibiotic like azithromycin, the 250 milligram daily for about the 2 to 3 years, or for sometimes the whole life. That is very important. So doing full blood count and the spirometry is very important in a patient with COPD. So for the assessment of the patient severity and the type of the underlying factor, which will be maybe infection or maybe the inflammation, where your management should be focused for that. So this is an pharmacological management is that, but out of all the non-pharmacological management, when you are going for exam, you always talk about the non-pharmacological management first, and the time will be over. You couldn't talk about your pharmacological management, where it is compulsory for you all to talk about that. So because of that, I advise you all to go for the pharmacological management first and then go to the non-pharmacological. So here the non-pharmacological is stop smoking cessation for this patient. And anyhow, if you are talented enough, so go for, the cessation of smoking cessation with your best management option by giving another dates for him to come and attend for that, motivate for that, as well as, the management of the dyspnea or whatever, the high protein diets and management of multiple comorbidities underlying like diabetes of this patient, right, and hypertension control. And this out of all, the pulmonary rehabilitation is the breathing exercise, which you need to give under the cover of the talented physiotherapist for him to come out with this suffering. And it's a real long-term suffering. Sometimes you may be needed long-term oxygen. So in such patients, you have to identify what is the cutoff point for you to provide long-term the oxygen in which the patient will be benefited for the better the life. So a palliative care matters a lot here. So in such a case, that is being the primary care physician, you can do a lot, and in spite of adding the high protein diets, hydration, and the preventive vaccines like pneumococcal and the H influenza vaccine for their correct patients detection and send them early. And in case that if it's patient not responding, send them for the chest physician. So those are the very important things. Once you detect the patient of COPD, diagnosis is within your hand. The capability in taking information as well as the confirm the diagnosis by correct techniques, and the peak expiratory flow rate and the spirometry is very important. Then full blood count to assess the eosinophil count is very important. Exclude the secondary infection and go for the management of inflammation by optimization of combined inhalers therapy as well as the ipratropium or thiotropium. So add-on therapy, and then go ahead with the preventive measures of the infections by pneumococcal vaccine, H influenza vaccine, and the long-term antibiotic therapy. And the avoid out of all, most important thing is avoidance of the triggers for my patients. Today, the avoidance of the dust. Being the mason, strictly we need to advise to wear the mask or during the work time or to be away from this dusty environment anyhow. Otherwise, we are not guaranteed his the recovery. So that's the best evidence-based the discussion that we have done. Any questions? Any questions for you all? No questions. Huh? So, as the president of this college, as since I have the vested responsibility to upgrade and uplift your knowledge in order to provide the better care for our patients as well as to train you all for the best, to become a best clinician in primary care is our college utmost the responsibility. So because of that, I have been committed so many times with my members, full-time members and the council, you all to provide the best contact care, best first contact care, tips for that and the training So in order to get through your exams with flying colors. So we have taken that responsibility. Throughout, we are going to provide you that the CPD activities, which is based on our patient management at base hospitals. So the base hospitals are the places where you can, the work with dignity, and as well as that is the place where you all have to have your card for specialist. So once you work there, you can have the full range of diagnostic facilities where you can independently work on your patients so that you will provide the best, the first contact care for your patient, so that whether to take this patient under your care and treat the patient and send them home, or treat the patient and do the follow-up management, or identify the patient to refer to the secondary and tertiary care. So because of that, it's very important. You are the proud members of the first contact care. So we are there to look after you all till your exam is over. We are the clinical trainers as well as the examiners of your exam. So we have taken the responsibility, being the college, to provide the best, the knowledge in order to, according to the training. As trainers, as examiners, we know what to do and how to train you all to come to the fulfill your exam criteria as well as the patient care. So there are some patients, so they are not trainers, that they have, this already started, training programs and teaching sessions where you will be ended up with, nowhere, right? So because of that, being the experienced trainers within this college, right, they will be taken classes on and off for you all to provide you the competence in primary care, and as well as that is according to the prospectus. And being the PGM trainers, we know what to do and not to do, and not to waste your time, because competency is competency. We can't play here and there for politics. So because of that, so I advise, and as well as the request humbly, being the president of this college, because we don't have any other agendas, but the only agenda is to, the train you all to have the success the same way that we practice in on our patients at base hospitals, to have the competency and to have the dignity like the other specialists where the base hospitals and above, right? So not like in divisional hospitals under the medical officers, the administration, we have been enough tempered, because with their jealousies and all, because being the administrators in the divisional hospitals are medical officers, just being MOIC, and it's enormous pressure that they put not to proceed like consultants. So because of that, you please be away from the mindset of being inside to get the training to be the consultant family physician in this divisional hospital. So because of that, having that, the clear message that I'm going to tell you, you are well recognized at base hospitals, right? So because of that, college has taken the responsibility to provide that dignity to practice for your patients with knowledge. So I'm there to provide this, the take-home message for you to think about, you are in par with the medical specialist. So because of that, this knowledge is very important to provide the best evidence-based care at the first contact, which par with the international standards, what other countries practice. So because of that, please keep that in mind. And we have to gather the knowledge to provide the best care for your patients at the first contact, whenever irrespective of the age and the gender. So, having provided this knowledge, we are continuously, every Thursday I'm going to do that, and Dr. Lalantha Senaratna will do the physical classes on Saturdays. So kindly please, take your time to be with us to provide you this guidance. And not only that, the MD holders, BFM holders are also there. Just medical officers are also there within the provinces that which we have done the capacity building program by the Ministry of Health. So I would like to thank you all for your patience and the mindset of getting motivation for this the learning programs. We will be conducting these programs in future as well to take you the consultant knowledge into your into your level so that you can come and ask any questions and clarify the matters for the better patient management. So thank you very much, and I always wish you all the best as the president of the Sri Lanka College of Specialist Family Physicians. And any other questions, if you have, I can give you 1 or 2 minutes, or even the few minutes for you all to come out. Thank you, Achini, for your provision of your best, the commitments, and with the knowledge you came out of the management of COPD patients according to the goal guidelines. Thank you so much for your commitment. Any other questions from the audience? Please don't think that the questions are, not to ask questions and your knowledge will be displayed. So that is not the way for the learning. So you display your whatever the gaps and all, so that you will be strengthened with the correct knowledge. If you have any questions, so we are ready, being the president of the college, as well as the trainer, as well as my trainee, also ready to answer for your questions. So come on, please. And this is the time that we have provided for you all. Any questions is all right. No questions for you all? Actually, how many of you, the people have been joined?
Madam, initially there
Madam,
were
Madam,
59.
Madam,
Sorry?
දැනගන්න පුළුවන් වේද? Hello,
Okay.
Madam. Just for the oxygen, what about the saturation we have to give for the COPD patients?
Yeah, that is, the even acute pneumonia or COPD patients, the
Yeah.
saturation should be the normally 96%, right?
Yeah.
Whatever the even if the patient is short of breath, of
Yeah.
course we have to think about that is completely the saturation has gone down, no? But
Yeah.
other than that, if a patient complains of the shortness of breath, like our patients, the getting
Yeah.
shortness of breath while the walking for less the 100 feet, so only within that they are getting, like that it differs, right? But
Yeah.
anyway, for you to without considering long-term oxygen, the patient saturation should be around the 95 to 96 at rest.
Okay.
Other than that, if it's going down below the 96%, we need to admit that patient for the further assessment with spirometry, as well as the need for the long saturation need to be monitored.
Okay, Madam. Thank you, Madam. Thank you.
Yeah. Any other questions? Let's thank you.
Madam, do we have to exclude tuberculosis before starting treatment or simultaneously?
Of course, that is why the exclusion of the other red flag symptoms or other disease. That is why you have to be competent in the taking histories. That is called data gathering, right? So once you get history correctly, if you skip the history not according to the way that we were taught, that is the presenting complaint, right? The presenting complaint duration and the analysis of your presenting complaint with association, worsening factors, right? And then go for the past medical history, then go for the social and the psychosocial history, right? And go for the concern of the patient as well. Then you can come to the at the end of history taking with your the correct application of the consultation skills, like talking to the patient nicely, establishment of the doctor patient relationship very well. Then patient will come out even without hiding anything, even agendas and all, to they give the information to you. So at the end of history taking, you should be able to come to your tentative diagnosis with the differential diagnosis and the most likely clinical diagnosis. Then on examination, but if you are not keen about the applying the practice of correct the application of your skills of examination techniques, because we have been trained you for application of the correct examination techniques, not just here and there. Unfortunately, so being the MRCGP examination for the international exams, there are so many rich people coming from Abu Dhabi, Dubai, UAE. They are not aware about what the correct technique of application of the examinations, the techniques that need to be corrected. If you are superficially applying that, and if you are wrong, you are going to miss the correct the findings by doing the examination. Examinations with correct techniques are there to find out the positive signs of examination, particularly to exclude the red flag, the symptoms that you have identified by gathering the symptoms of gathering symptoms, where you need to exclude those red flag symptoms, because we have been trained in breadth of clinical disciplines, not in depth. So but our prime duty is to identify the red flag symptoms, and the from examination we have to exclude those symptoms or confirm the symptoms by correct sign detection of correct clinical signs. If you are fail to do that, the examination put the application of the examination technique, you will be missed the correct the positive red flag signs which came from the symptoms. So then you are a failed doctor, that you have missed it, the positive signs. But once you have the competency, you should be able to detect or exclude these positive red flag symptoms confirmed by the clinical examination, where you can be ended up at the examination from the data gathering, history taking, that you came to the tentative diagnosis, but you confirm your diagnosis clinically by examination. So the clinical diagnosis can be confirmed by the positive findings which you have found from the examination, right? So then, so you are there to manage, go ahead with the necessary investigations and the follow-up plan. So because of that, it's very important for you all, that being the first contact care physicians need to know this. So then you can go ahead. Shall I answer your question? Hello?
Yes, madam.
Okay. So your competency matters a lot in first contact care to confirm the diagnosis by excluding red flag the diseases. That is the main important thing in primary care. If you find that either the positive symptoms or the positive signs, then you have to hand over to the secondary care. Any other questions? And another the small message that I would like to tell you, for the being the very much juniors that you have joined with this family medicine. So I'm there to welcome you all with the very much the happiness and the dignity. So I'm going to take you for the felicitation and the welcoming you all to the on board to the family medicine family. Then we are going to have some some recreational the event which we are going to your seniors will go into the organize it very soon. So don't think that you are have been cornered. No, we are there to support you, the, improve your competence in family medicine and take you on board to practice as consultants with competency. And we are being trainers to help you all for the formative training in order to provide your best competencies during our training time and to assess at the exam. But after provision, the best the competency for you all. So because of that, so you should be with us. Being trainers, I'm telling you, I'm there to we all together, 14 board of study, the consultants who have been the board members. So we are there to support you. So don't worry. We need your the sacrifice for this program to improve your competence. I know that you all are adult learners. You have family commitments like me. But anyway, so you have to take the priority on this journey to become competent consultant family physicians one day. So that is our, the dream for you all to train to get this competency and to practice, the correct, the evidence-based practice in family medicine in first contact care. So we assure as the college and as the president, and we will be there to support you. So it's all right. And you are almost welcome to our the family medicine family. Thank you very much. So any other questions? I hope that you all have the benefit